And so with that, we'll go ahead and get started. If you're having any technical issues, you can go ahead and chat those to us as well. And we have some folks who can help you out. So I just wanted to say thank you so much to everyone who is joining us on today's webinar, Demystifying Telehealth, What Families of Children with Special Healthcare Needs Need to Know. We're really grateful for everyone who's taken the time to be here today to learn more about telehealth during the COVID-19 pandemic. And we're really excited to have some great presenters here with us today to share some important information and useful strategies to make the most of your telehealth appointments as we move forward into the new way that we're now navigating healthcare. So I'm going to go ahead and start a poll just so we can get a good idea of the folks who are in attendance today. The first question is just asking, who do we have here today in the webinar? Are you here in the capacity of a caregiver or a parent of a child with special healthcare needs? Are you yourself an adult with a special healthcare need or disability? Are you a professional who works with families? And the second question is just to kind of get an idea of how everybody's feeling today. So you can go ahead and answer that poll. And in the meantime, I will go ahead and give you a little bit of information on Family Voices of California. Tip, can you go to the next slide, please? Thank you. So as folks know, if you're familiar with Family Voices of California, we do have an annual event called our Health Summit. And it's usually every year in March in person in Sacramento. And this year we went ahead and rescheduled to a series of online webinars. So this is one of those webinars, and we just wanted to say thank you so much to our sponsors who are up on the screen, our Health Summit sponsors. We just really wanted to express our gratitude for folks who allowed this to happen today, and thank everybody for being flexible as we kind of do this new version of our Health Summit, which is online and spaced out over several webinars. So thank you so much. And then just a bit about Family Voices of California. We are a statewide collaborative of parent-run centers working to ensure quality health care for children and youth with special healthcare needs. We at Family Voices build the capacity of parent-run centers throughout the state to provide families with the information and support they need to make informed decisions about the health care of their children. Family Voices provides information and a forum for parent centers and families to advocate for improved public and private policies, builds partnerships between professionals and families, and serves as a vital resource on healthcare. So with that, I'll go ahead and end the poll so we can take a look at the results. It looks like we have a good amount of parents and caregivers here. Most of us look like professionals, and we have some folks who describe themselves as none of those three. So we're really glad to have everybody here today. And it looks like, I'll go ahead and share the results so everybody can see. It looks like a lot of folks are excited to learn today, and we have a few folks who are anxious and overwhelmed as well, and I understand that feeling. So with that, I'm going to go ahead and introduce our facilitator for today, Erin Kelly. Ms. Kelly brings 20 years of public health and healthcare experience to the Children's Specialty Care Coalition. She has served as the executive director for the Children's Specialty Care Coalition for the last 6 years. And the coalition is a nonprofit association that represents nearly 2,500 pediatric subspecialty physicians that work at children's hospitals throughout the state. Its mission is to ensure children and youth with complex healthcare needs have access to timely, high quality, and equitable care. Children's Specialty Care Coalition has been a big proponent of telehealth for a number of years as a way to improve access and quality of care, as well as its ability to reduce barriers to care for children and families. So with that, Erin, I'll go ahead and pass it off to you. Thank you so much for being here today.
Yes. Well, thank you, Allie, for the warm introduction. I'm thrilled to be facilitating this webinar. Before we get started, I just want to express my appreciation to Family Voices and its skilled team for its broad array of educational programs and services and supports it offers to children and families, and for its adaptability to transform the annual Education and Advocacy Summit to this dynamic, informative webinar series. It is also wonderful to have interpreter services available. A special thank you to those interpreters, Kai Lu, as well as Oscar Areta. It's also great to have such a tremendous turnout in terms of participation. We know your time is precious, and we appreciate you taking the time to spend the next hour with us this morning. We have an all-star lineup of speakers to discuss a very important and highly relevant topic. The specific aims of this webinar are to increase understanding about telehealth, how it can be used, its value for children and youth with special healthcare needs, and what policies are needed to ensure access and sustainability. Telehealth has been around for many years, and depending on your provider or your health plan, you may have had experience with it prior to the pandemic. However, it was still not very commonly used in pediatric care statewide until the emergence of the COVID pandemic, which really catapulted telehealth to the forefront of healthcare and rapidly accelerated its use. Now, telehealth visits, either by video or phone, have become integral to providing healthcare during this pandemic. The California Healthcare Foundation statewide survey of almost 2,500 California residents found that 62% of people who needed care since the start of the pandemic had visited their provider via telehealth. 3/4 of those respondents who had a doctor's visit by phone and 65% of those who had a video visit reported being more satisfied or just as satisfied with telehealth as they were with in-person appointments. Many experts say virtual care is here to stay and will continue to be an important tool to deliver quality care when clinically appropriate. For many Californians, the ability to connect with a doctor or their care team by phone or video is the difference between canceling a visit because of the barriers are too great or getting the timely care that they need. However, many of the policies that enabled its comprehensive use during COVID are temporary and set to expire at the end of the public health emergency. So there is still critical advocacy work ahead to ensure that many of these policies become permanent in California. Fortunately, California was one of the most progressive states in the nation as it relates to telehealth policy pre-COVID, but still barriers remain, which our panelists will speak to during this session. Just a few housekeeping items before we get started. The webinar will be recorded and can be accessed at a later time. Feel free to use the chat box to submit your questions, and the Family Voices team will be monitoring the chat box, and we will have speakers address questions at the end of all of the presentations and remarks. Now it's my great pleasure to introduce our panel of speakers. Kwong is the Executive Director of the Center for Connected Health Policy. Ms. Kwong is a foremost expert in telehealth policy. I have had the privilege of working with her as part of the California Telehealth Policy Coalition, a consortium of over 60 organizations that are dedicated to advancing telehealth policy here in California. May has written numerous policy briefs, crafted state legislation, and led coalition efforts on a variety of issues. She has published several articles and has been consulted by state and federal lawmakers as it relates to telehealth legislation and policy. Our second speaker is Dr. James Marcin. Dr. Marcin is a critical care physician at UC Davis Children's Hospital. In addition to his clinical work in the pediatric ICU, he is a nationally recognized expert on telehealth and has conducted extensive research and advocacy in telehealth related to access and quality of care, particularly as it relates to children with special healthcare needs and acutely ill and injured children in rural communities. Our next panelist that will be speaking is Ginger Moyles, who is a special needs parent advocate. A parent of 3, Ginger lives in a very rural part of Northern California on a small farm. Her youngest is 12 and was adopted with a rare genetic syndrome, which requires care and many time-consuming appointments. We are happy to have her here today to share her telehealth experience and how it has impacted her life and her daughter Chelsea's life. And last but not least, we have Nancy Netherland, who is also a special needs parent advocate. She is the mom of 2 amazing kids, Amelia, who's 12, and Sarah, who's 14. And Nancy was lucky enough to build her family by adopting infant siblings through the California Foster to Adopt program. Both kids were born with medically complex conditions, and Amelia suffers from a rare chronic complex disease that demands significant medical intervention. Nancy also sits on the state's Medicaid Children's Health Advisory Panel, also known as MCHAP, and the Cal Ames Foster Care Working Group. Nancy also started a nonprofit, Kids and Caregivers, dedicated to caregiver wellness. So thank you all for joining us today, and I will go ahead and turn it over to our first speaker, May Kwong, who's going to provide an overview of telehealth and the current policy landscape.
Thank you, Erin, and thank you, Family Voices, for inviting me today, and thank you, everyone, for attending this session. As Erin mentioned, my name is May Kwong. I'm the Executive Director at the Center for Connected Health Policy. Next slide, please. I have to always start off with a disclaimer, so I don't know if you noticed my title. I'm an attorney, so this is just something that I do almost automatically. So any information I provide today is not to be considered legal advice. It is strictly for informational purposes. CCHP always recommends, if you want a formal legal opinion, to please consult with legal counsel. And if I also happen to mention a company or show some type of product, know that neither I nor CCHP has any type of relationship or affiliation with such a company. Next slide, please. A little bit of background about CCHP. We were actually established underneath the Public Health Institute in 2009 to be a California telehealth policy organization. But a grant became available through the federal government through HRSA to be the federally designated National Telehealth Policy Resource Center. We applied for that in 2012, and we've been serving in that capacity ever since. So CCHP has sort of this dual focus because we are located in California. We started off as a California organization, have very deep roots here, still get some funding from private foundations in California. So we do focus still on the state, but we also have a national portfolio as well. So we actually work with all of the states throughout the country as well as the federal government. We are also the administrator of the National Consortium Telehealth Resource Center. I'll explain that in a little bit. And Erin mentioned that we are the convener for the California Telehealth Policy Coalition. And again, I'll explain that in a bit as well. So next slide, please. The National Consortium Telehealth Resource Centers are made up of the 14 telehealth resource centers. They're underneath the same grant program that CCHP is under. California has its own telehealth resource center. It's called the California Telehealth Resource Center. The other states actually are underneath different telehealth resource centers. So each regional telehealth resource center serves specific states. California is the only one that only serves one state simply because of the size of California. However, we do all work collaboratively together. So we formed this consortium, which is an affiliation among the 14. In addition to the 12 regional resource centers that cover specific states, you have 2 national centers. CCHP is the one on policy, and then there's one on technology as well. And we work together as much as possible in order to really give people who are interested in telehealth sort of the full range of telehealth information that they may have. They may have questions regarding how do I start telehealth? Where do I find it? What are the policies around it, such as the laws, or how do I get paid for it? And also what technology, I might be interested in using. So when you reach out to a telehealth research center, you have that full experience, full knowledge of like all the questions that you might have about telehealth, to be answered by the resource centers and the various components involved there. So I encourage you, if you have questions around telehealth, you're free to reach out to CCHP, but also really reach out to your regional telehealth resource center, the California one. And that's the URL in which you can find them. If you have friends or you're located in another state, you can definitely go to that URL to look up one of the other regional resource centers, or if you're interested in what's going on in a different state. Next slide, please. So one thing that CCHP does is that we track all of the telehealth laws, policies, and Medicaid and regulations related to telehealth. And that's the information that we put up on our website. It's free and available to the public. We keep it updated fairly regularly. We do a spring update and a fall update, and we've just finished our fall update. So the information on our website is good through October 2020. Now, it does not include the COVID information. That's on a separate section of our website. And the reason for that is a lot of the COVID changes have been temporary. So what is on our interactive map is the permanent changes, but there's a different section with the COVID temporary changes that you can access and see what is the current policy right now in response to COVID. Next slide, please. So for telehealth policy, it can really be split up in two ways. It can be split up underneath Medicaid and Medicare. For purposes of today, I'm just going to focus in on Medicaid. There were a lot of changes, and you probably heard this, that happened in Medicare in response to COVID. One of the reasons why is because Medicare policy was really out of date. Nothing had really been changed in more than a decade. So they had a lot of catch up to do when COVID hit. They had a lot of changes to make. And part of the reason for that is because a lot of that Medicare policy is in federal law. So they needed to wait for Congress to act before anything can be changed. But we're going to set that aside and really focus in on Medicaid, specifically California Medicaid. Next slide.
I want to thank all the presenters and let them know that we have interpretation. And if we could please slow down, one of the interpreters asked if we could slow down the pace of speech. Thank you.
Okay. So for existing telehealth policy, a lot of what exists before COVID-19, when we talk about telehealth policy that is specific to telehealth, it is related to what is paid for, what is covered. So, and that reimbursement policy, what's paid for, can be broken down into 4 elements. And those 4 elements are, what, where, who, and how. So what service is covered? Where's the patient located when the service is taking place? What modality is used? And what that simply means is, how are you delivering the service? What technology are you using? And who is the provider? So for example, let's say you are a Medicaid program and your policy says, we are going to reimburse for telemental health services when the patient is located in a doctor's office, when you're using live video, and when it's being provided by a psychiatrist. So that's how a lot of your telehealth policy before COVID-19 existed. And that's where a lot of changes really focused in on that, what gets paid when you use telehealth. Now, there are other policies, and I'll talk about them a little bit later, but that's sort of your main bulk of what existed and why you saw a lot of temporary changes addressing those things, such as, oh, we're going to now allow these groups of providers to be able to use telehealth and get paid, or, oh, now we're going to cover this service. Or two of the big things is, we're now going to allow the service to take place in the home and we'll pay for it. Or we'll now allow the use of audio-only phone and we'll pay for it. So if you were wondering why some of the policies, the waivers, the temporary relaxations focused in on those specific things, it's because that's how a lot of the policy before COVID-19 was structured. Next slide, please. So Erin mentioned this, but California before COVID-19 was actually not in that bad of a place with their telehealth policies in Medicaid. So Medi-Cal actually updated their telehealth policies the summer before COVID-19 hit, and they actually greatly expanded what they were going to allow, such as, where it could take place. They expanded that and made it very specific that it could take place in the home. The types of services that we covered. Again, they were very clear that with certain exceptions, Basically, any service that Medi-Cal typically covered, you can use telehealth to deliver that service. Now, some of those exceptions were, if there was a service that required you to like touch the patient, you can't do that over telehealth. But basically any other type of service, as long as it's something Medi-Cal typically pays for, will cover it. And they also allowed the provider to decide what modality they can use. They can use what's called live video, which is what we're doing now, just live video, real-time interaction over video, or something called store and forward, which is capturing of information and sending it. Think of it like a very secure email system of delivering services. So for example, you go into your doctor, you have like a skin rash. Your doctor's not quite sure what it is, takes a picture of it and sends it to a dermatologist. And then the dermatologist comes back with a diagnosis or further instructions. So that's storing of information and then forwarding it. So California Medi-Cal policy for telehealth, not that bad before COVID-19. There were other limitations, especially around federally qualified health centers and rural health clinics. They have limitations because of how they're structured. They don't necessarily, the rules they have to follow don't necessarily fit well with telehealth. And that's not completely Medi-Cal's fault. There's a lot of federal laws and rules and regulations that they have to follow. And again, I mentioned Medicare had not been updated in a while. Neither has like the policies around FQHCs and RHCs and how they can use technology. So again, we're butting up against like really sort of out of date rules or laws sometimes. So California, their consent, we've had this for a while. It can be oral or written. And then with commercial plans, when we're not talking about Medi-Cal, with commercial plans, there was a law that was passed in 2019, but doesn't go in effect to 2021. And that was basically directing how commercial plans would cover telehealth. So it's still not in effect yet technically because of the date that was on the bill, although there was an executive order to like speed that up and like have plans cover telehealth before like January 1st, 2021. But overall, California not in a bad place when COVID-19 hit as far as their telehealth policy is concerned, even though there were some other types of barriers like around FQHCs and RHCs. Next slide, please. So these were some of the temporary changes, and they're very specific changes. The biggest one really was around use of telephone, because that was not one of the things that happened or was available before COVID-19. So Medi-Cal did come up and say, we will allow services to be provided by audio-only phone, and we will pay the same amount. Again, there were also FQHCs and RHC rules that they had issues with that they were still a little bit limited before COVID-19 just because of the different rules that they have to follow. Medi-Cal, expanded that. They also checked in with the feds because some of those were like federal rules that they felt they needed CMS to like do approval on. So they did do that and expanded that. So, and then there were a couple of other things as well, very specific things, but they did do these expansive policies. However, they are temporary. So what a lot of these temporary waivers are tied to are the public health emergency that's declared on the federal level. So once that public health emergency either expires or is declared over, these temporary changes go away, and we revert back to what the situation was before COVID-19, which means like FQHCs and RHCs still have like limitations, and telephone will go away too. Next slide, please. So other issues beyond just the reimbursement, there is also prescribing, in that you can use telehealth live video or the asynchronous version, what I talked about, the store and forward version. So that was, again, something that existed before COVID-19. And then so California, again, was like in a fairly good place in that section. But then we also have other issues that impact the utilization of telehealth. And those are broadband, licensing, education of providers and consumers on like what is available, what can you do via telehealth. The licensing issue is that you need a license in order to practice in California, provide services if you're from like another state. And then broadband, it's like having that connectivity in order to like have this telehealth services. And then out-of-date forms and regulations. What we've encountered also during COVID with greater usage of COVID is that some forms are just simply out of date, like in the department. So for example, if you're a skilled nursing facility and you were trying to get what they call an originating site fee, which is if you're where the patient's located, you can get a little bit of money back. They actually didn't have a line on their form to like write down that they are entitled to that. So they couldn't get the fee because there was no space on the form to write that. So updating outdated forms and regulations as well. Next slide, please.
This is just a quick time check. We have about 2 minutes until we need to move on to our next presenter. Thank you.
And we're almost done. So where do we stand now? Still, these are temporary changes. Nothing has been made permanent in the last legislative session. So we are still tied primarily to that public health emergency on the federal level, which has been renewed to January 21st of 2021. It will need to be renewed again if we want to go beyond that, or some of these changes would need to be made permanent. Otherwise, again, we revert back to like pre-COVID-19 era. There was no significant legislation signed this past session. There were 2 pieces of telehealth legislation that existed before COVID-19 that was sent to the governor, but he vetoed both of them. And one of them, he gave a message of like, they're currently in a process of evaluating Medi-Cal's telehealth policies. So we'll see what happens with that and what they come up with in their evaluation. Next slide, please. I mentioned the California Telehealth Policy Coalition. They are working with like their many partners to see what can be done to keep some of these changes permanent. These are a list of their recommendations for permanent changes here. And as I said, as Erin mentioned, it's actually up to about like 100 different organizations now working towards all this. The coalition hopes to have like a final slate of that. But we're also working with other partners as well to like look at what's the best strategy in like keeping some of these changes around. Next slide, please. And these are just a couple of URL links to CCHP's resources, and that is it for me.
Great. Well, thank you, May, for that excellent policy overview. And so next we have Dr. Marcin, who's going to give us some specific examples of how telehealth is used for families and children with special healthcare needs. Thank you, Jim.
Thank you. Thanks, Erin. And thanks to Family Voices of California for allowing me the opportunity to share this information. And thanks to all of those that have tuned in for this talk. Next slide. In general, providers and patients think that there are a lot of opportunities where telehealth can improve access, the patient experience, and the effectiveness of healthcare. Access can be helped because sometimes people live very far away, and using telehealth can mean that they don't have to travel long distances. Also, as you know, the specialists are regionalized in big cities, so sometimes it's difficult for those that live in rural areas to gain access. This can create an improved experience for the patient and their family, not having to travel. We also think that sometimes telehealth can increase the effectiveness of healthcare delivery because appointments won't be missed and more providers can join the video all at one time, improving communication within the team of healthcare experts. We also think that this improved model of care can sometimes result in a higher value and lower overall costs of care, especially if CCS is having to pay for travel for the patients. Next slide. This is a slide just demonstrating the overall use of telehealth for Medicaid patients across the country before the pandemic and after the pandemic. You can see on the right that nearly between 10 and 20% of all encounters in the United States have used telemedicine since the pandemic and COVID has struck. Next slide. What I will talk to you today about is how telehealth can be used, in particular for children with special healthcare needs. I'm going to talk about how telemedicine can be used directly to your home, how it can be used to your primary care provider's office, how it is also being used in schools and other off-site non-healthcare facilities. and how it can be used for both acute and urgent care monitoring, as well as continuous home monitoring. Next slide. This is an example of how telemedicine can be delivered right to your home. You can go ahead.
Just for kind of documentation purposes, can you tell me the location that you are? I am in my apartment right now. And are you in a private space where we can talk about your health matters freely? Yes, definitely. Why don't we start with what brings you in today? What can I help you with? Well, I've had a cough for about, I don't know, 5 to 6 weeks. And have you gone to the doctor at all about this in the past 5 to 6 weeks? We can take a look at that x-ray. I'm just going to ask you a couple more questions. Thank you, doctors.
Next slide. So again,
Just for kind of
for these purposes, you can now see your doctor at home. And so hopefully if you don't need to do a physical exam, or if you don't need to get laboratory tests, you can check in with your doctors using video in that way. This is another example of how, that's okay, Pip, where it can be used to your primary care provider's office.
I'm the provider for our telemedicine neurology patients, and I've been doing this for the past 6+ years. Dr. Chang is our pediatric neurologist at UC Davis who provides the service. So I know the specialist well. Before she can make recommendations, I already know what the next thing she's going to ask for. So we work like a team. Once she has obtained the history, then I will do the physical exam for her while she is looking at the child. So if we did not have telemedicine neurology at our facility, I worry about missed appointments. It's very hard for families to travel from here to a children's hospital. The closest we send them to is UC Davis.
As you know, Sacramento is about 2.5 hours, maybe 3 away. Well, by the time I get reached down there, figure out where I'm going, now I'm tired, I'm exhausted. If Reese's having seizures and I am driving, then we've got a problem. So when you ask me how telemed helps, it's like this right here is one step that makes it easy for me, because Reese's getting the same treatment that he would get if I took him to Sacramento.
Thanks. So again, that's an example where the family and patient can go to their local provider, wherever that might be. In this case, it's Reading, and have the specialist beam into your regular doctor or provider's office. Next slide. It's also being done to the school. And I saw in the chat, there was a question about the MTU, or medical therapy units. Some health systems are now using telemedicine to project the physiatrists to the school-based clinic where the occupational and physical therapists are. This is where UC Davis is doing this now to 8 different school systems to be able to provide care for children enrolled in the medical therapy program. If there's other questions on that, I can certainly share how your schools can gain access to this technology as well. It's also being used in schools for routine health screenings and health education. Next slide. So we'll skip this video in the interest of time, if that's okay, but it can also be used. So let's say your child gets sick in the middle of the night or on the weekend when your regular doctor's office may not be open. More and more health plans and health systems are letting you see a doctor for acute care if they're sick or they need a medication refill and such. And so this way you don't have to go to an urgent care or emergency department. And this is a video showing how that works, but in the interest of time, I'll just go to the next slide. More and more, the technologies are also being available for children with special health care needs, where we can do remote patient monitoring. We can actually communicate with ventilators, pulse oximeters, scales, glucometers, and other home technology devices using Bluetooth to be able to monitor children that are continuously being monitored by medical devices. These technologies are not routinely used or monitored, but they are in some special pilot projects. And I'm happy to share with those in California resources throughout the state where this is being done. Next slide. So there still are barriers, unfortunately, for the providers, that is the doctors and the nurses. We're not able to do the physical exam. We clearly can't do things like give immunizations. Sometimes it's difficult to communicate with the family over video. We need interpreting services. Sometimes there's lack of privacy, and also there's a perception of quality. We want to be able to provide you the best quality of care possible, and we don't want video to diminish this quality. Next slide.
This is another quick 2-minute time check for you, about a minute 30 seconds. Thank you.
Thank you. Oh, was there a slide before that? Yeah, so now that COVID has hit, we hope that this is an opportunity for the healthcare system to reimagine how we deliver care. There are different ways for your provider to communicate over email to ask specialist questions so they don't have to call or send you to the specialist. Hopefully, patients and families have access to direct video connections with their providers in their own home. Again, it can be used in schools or even in your regular doctor's office to get specialty access. So we're hoping that after this COVID, we're able to leverage these telehealth technologies to provide the most patient-centered care possible. I think that's it. And I want to thank everybody for their time, and I'm very happy to answer any questions.
So I think we're going to save questions till the end, but thank you so much, Dr. Marcin, for your tremendous work in this space. And I think the videos and the visuals really help crystallize its telehealth's many uses and its benefits. So thank you for your presentation. So next up, we have Ginger Moyles, a parent advocate who has used telehealth and will speak to her family's experience with it. Thank you, Ginger.
Hi, I'm Ginger, and I live just south of the Oregon border in Siskiyou County, and I travel frequently to UC Davis for my daughter's medical care. She was adopted by me as a single parent out of foster care in 2011, but she's been in my home since she was 2.5 months old, but I did not get medical rights until the adoption was final in 2011. But I've taken care of all of her medical needs by myself until I recently got married a couple years ago. She was finally genetically confirmed by UC Davis in 2014 with Spritz-Goldberg syndrome, which is a rare connective tissue disorder. But I live 4.5 hours away from Sacramento. That's if I do the drive with no stops. I have never done it in one day appointment, and I've never done a one-day appointment in under 12 hours. We average about 25 appointments prior to COVID a year at UC Davis. We have about 5 appointments in Redding. Then we go into Oregon for one of her specialty cares because we're actually closer to Oregon. Depending on the type of appointment and the time of day, we sometimes stay overnight. Due to her behaviors, fear of the doctor's offices, and compliance most of the time. A lot of these appointments are mainly me informing the doctors what has been happening, and sometimes if they can get a physical check, they do. If we have to run a test, we have to put her to sleep. She's very incompliant. Since most of her issues are internal, they does require a lot of diagnosis and monitoring through x-rays, MRIs, CTs. January of 2018 was my first experience with telehealth, and it was done with a doctor at UC Davis that was utilizing it. We utilized a doctor's office locally that did all of her pre-appointment, height, weight, whatnot, that they monitored the appointment, and then we talked with the neurologist via telehealth. Since COVID-19, it's been a blessing. We've been able to do these from home. I can concentrate on what is needed. I don't have not fighting her under a table. I'm not fighting to get her weight. She's fine with just checking in on the computer and going to do her thing. She's mentally delayed. She's not going to give the doctors a whole lot of information, even if we're in person, which she still doesn't do it over telemed. It's with me. So to drive a minimum of 5 hours one way, to have her not be compliant in a doctor's appointment is very hard for me. It's time consuming. It's hard on her. If you've ever traveled with a special needs child, depending on their needs, you have G-tape, G-tubes, wheelchairs, trachs. They're exhausting to haul, unload, pack up, stop along the way to do feeding, suction, you name it. It's a very long drive and very hard on these kids. So to be able to do that from home is amazing for us. I have always wanted this. So COVID is kind of a blessing for me in a disguise. I get to keep her in school. Things are great. My big fear is that when this emergency is over, that it would go away. The other problem that we have in our area is that we are very rural, and connectivity is an issue. We have families that don't have reliable internet access, but their phones work, and they may not be able to do it by a video or may not be working at that moment. It would be great if telephone was a full access for the appointment in appropriate cases, until something happens to where connectivity is a better quality in these rural areas. But it's a long way to travel, and because it's a long way, the connectivity can be an issue. I don't know what else to say except that it needs to stay in place. The doctors that I have worked with at UC Davis have been amazing at utilizing telemed. Even if I've had an in-person appointment scheduled and something has come up where we were ill or the COVID cases have changed, I just call down and they change it to a telehealth. We did a full craniofacial panel via telehealth, and then I had to go back down after that for the tests that they deemed necessary during that telehealth appointment. But it still saved a bunch of time, only having to go down for the necessary appointments that they needed. I know that in-person has to be done for x-rays and MRIs, so those are great. But once they have those internal imaging, it's great to get those results via telehealth or by phone. So I appreciate this, and I appreciate your time and the efforts that all of you and the doctors are taking to make this an effective form of medical care for those families, that this is really helping. I appreciate your time. Thank you.
Thank you so much, Ginger. You've been a tremendous advocate. I know this is one of a number of briefings that you've participated on and have shared your experience, and your daughter's beautiful. I love the pictures. It's great to have. So, okay, now we have Nancy, who's going to share about her family's experience with telehealth.
Thank you, and thanks to Family Voices and to all the policymakers and providers of all types who are making care more accessible for our kids with special healthcare needs. I'm the mom of two kids with medical complexities who are formerly of foster care. So we use Medicaid. And I find it a little bit ironic. I do data strategy and I work for FQHCs for my day job. And I've been working on these amazing telehealth programs that had not until COVID really touched the lives of my children. Next slide, please. So I think of telehealth not just as a welcome change in accessing medical care, but also a portal to childhood. Next slide, please. What if you could give your kid or your child an extra 5, 10, or 15 hours of childhood a week? I think about that a lot as a mom who's got a daughter who has a fairly complex care team. I often imagine her being in the park instead of a waiting room, waiting for her beloved bubble tea instead of her discharge paperwork, or standing online at the zoo or the little farm instead of waiting to register for a medical specialty. And with the right care delivery system, that can be a reality. Next slide, please. So I love data. So I went back and took a look at some old calendars. You're seeing in the background an old, very old, a few years old, a care map, and wanted to look at kind of what we averaged in terms of appointments. And we averaged for pre-COVID 4 or 5 appointments a week. My daughter has a rare incurable multisystemic illness. She's got a genetic component that's been recently diagnosed. She also loves horses, bubble tea, her dog, her sister, and Fortnite, but not necessarily in that order. She has over 20 specialists, and I won't go through them all, but rheumatology, immunology specializing in IBD, gastroenterology, hematology, general hematology, genetics, oral medicine, a bunch of neurologists, neuro-ophthalmology, pedi-gyn, neuropsych, derm, ortho, endo, pain management, cardiology, pulmonology, and so it goes. And that doesn't even count her other regular providers, which includes the pediatric infusion team, inpatient, dental, imaging, labs, therapists, etc. So prior to COVID, she saw some of her specialists monthly. Her condition changes a lot. So her health has not always been stable. It's getting better though. She saw most of her specialists quarterly. She has hospital-based infusions every 4 weeks, regular procedures that are day long because she has to go under for scoping, biopsy, and stuff like that. Pediatric pain management and palliative care. And then she's got things like physical therapy, integrative medicine that are weekly. And that's when she's not acute or inpatient. So it works out to be about 4 or 5 appointments a week. Next slide, please. And each of those appointments takes about 3.5 hours. We now are able to live, and we've always wanted to live away from the city, but we couldn't because of her care. But prior to COVID, we had to count 2 hours of travel round trip, and that was to go 22 miles. Conservatively, we needed to add 45 minutes for waiting, though realistically cycle times have been up to 2 hours and never less than 30 minutes. Then there's the actual appointment and then the follow-up to the appointment. So really, when I do my calendar, I have to put 3.5 hours for each appointment. Next slide, please. That ends up being about 17.5 hours per week per kid. Now, my oldest daughter had another completely unrelated condition. She was in a clinical trial that I'm very grateful to say, has been very successful. But during that clinical trial period, on top of both kids' kind of what we consider routine management care, it ended up being about 17 hours per week per child. And literally there were weeks where I couldn't make all the appointments because I couldn't make the calendar work. And I had to make some hard decisions. Does one kid get to go to neuro and the other skips her pain management appointment because of the travel and waiting period time involved? I also took a look at what really happened during those appointments. And I realized that really about 20% or 1 in 5 of every minute that I allocated for care was actually time seeing a provider. And that really was huge when I realized that. I also realized that we were trying to schedule all the stuff between roughly 8:30 and 5. And during that same period of time, that's when school happens, IEP meetings. If your child doesn't feel good, that's when they stay home to rest. play dates, and just a lot of normal childhood stuff. Not to mention, I work full-time. I mean, I try to work full-time, I can't. Next slide, please. This ends up being a lot of moments lost to childhood, and moments that don't necessarily have to be dedicated to getting care. So what I realized when I look at my numbers and I look at my data, a lot of my time getting care for my kids is spent in waiting rooms, waiting for discharge paperwork and or travel. So the good news, and this is the upside of COVID, and they're not a lot, but the upside of COVID is our providers had not been using a lot of telehealth. We'd had one telehealth specialty care appointment prior to COVID. With the advent of COVID, what has been up to, and it's not always 17 hours a week, but that time is diminished now to about 4 hours a week for telemedicine. We're actually doing, we're doing therapy, we're doing pain management. We've even been able to do some physical therapy online where I'm the hands of the physical therapist, and other types of things that are routine weekly care for Amelia. Now, that doesn't mean that we don't still go in. I mean, she's got infusions that last 7 hours every 4 weeks. Next slide, please. But we have been able to eliminate travel time. We've minimized wait time. I mean, that is an amazing thing. She's much more comfortable. I, like other moms of kids with special healthcare needs, by the time we get to an appointment, usually my kid is pretty unraveled because we've been traveling for so long, we've been waiting for so long. So there's something really lovely about the mindset in which she enters appointments now. Not to mention she can bring her animals into her appointments, and those really offer her a lot of comfort, and she is communicating significantly better with her providers. And I do a lot of communication for her, but her participation has increased. There's a reduction in a financial burden involved with traveling, and it's also removed geographic restrictions. For the first time in a long time, our family can travel and be other places and still get medical care. And the other thing is there's unprecedented care coordination and collaboration. So I am obviously a huge fan of telehealth and telemedicine, but our providers can now show up at the same place in the same time. Amelia's got some conditions that are so rare that they're not pediatric specialists. So we've got adult medicine folks who need to come in, like there's a special form of hematology and there's a certain soft palate surgeon. And it's been remarkable to see adult and childhood specialists together, really rallying around the same child at the same time because of telehealth. Next slide, please. So I know that there are problems with telehealth, and I know there are issues with connectivity. I know that there are problems with the digital divide, and I also know that there are problems with privacy. My kids take their really private calls in the car, which is not perfect, but it is a solution. And so I just want to say that I know that we're at the beginning. I think we're at the beginning of a really important change in healthcare delivery. I want to say that this form of healthcare, even if it's in its infancy, is no longer demanding that my kids sacrifice hours of their childhood to receive medical care. So I look at telehealth as an opportunity to spend less time doing this. Next slide, please. And more time doing this. Because we're not spending so much time accessing care, we're spending more time enjoying moments of wellness and really embracing childhood. Thank you.
Thank you so much, Nancy, for that great presentation. I heard Nancy speak at the MCHAP meeting, and she used a term revolutionary. And I think the moments of lost childhood, it really can resonate with all of us, right? Having that time saved so that they can do what they enjoy and do what they need to be able to do to kind of continue to grow and flourish. So thank you so much for your presentation. And we We have just a few minutes left before the close of the hour for questions for any of our panelists.
Hey
So
there.
I will give a moment and here, take a peek here at our question box.
I don't know if you can hear me, but I've got one in Spanish that I can read out.
Great, thanks.
So it says, good morning. Telehealth applies to CCS services, more specifically with MTU services, such as monitoring equipment like easy standers, trainers. Since the quarantine began in March, there is no physical therapist who monitors the equipment at home. The person who's in charge of my case is an occupational therapist, and let us remember that equipment supports the advancement of progress. But if they are not calibrated properly, they could damage your health, such as backs, hips, knees, etc. We have been forgotten by the service provided by CCS in San Lorenzo.
This is Jim Marcin. I can't speak for all of the medical therapy program or the individual medical therapy units, but I can say that UC Davis and our rehabilitative teams are advocating at county and the state level that we employ more telehealth for the medical therapy program. I'm very happy to communicate with your county, your CCS medical therapy program for your county if you'd like to contact me after this talk.
Great. So I don't know that we have any other questions just yet. I have a question for Dr. Marcin. How can families optimize their telehealth visit? And you know, how can they best prepare for one if they haven't had one yet?
Well, so sadly, I think it's not well used by many providers. So sometimes providers need to be reminded that they can use telehealth. So I encourage you to speak to your primary care providers and your specialists for every appointment. Is this possible to be done over telehealth? However, as you know, regarding that question, it's important that the family have good access to bandwidth. Make sure that they have video capabilities on their phone or on their laptop, computer, or tablet. Many devices will allow testing of this prior to the appointment. Make sure that if you do your appointment, that you do it in a secure location. If you're at home, that's fine, but you need to put everything away. We've had some families call in from their car, which we don't encourage. So I think talking to your providers to make sure that it can be done, but also making sure that you have tested the technologies. Sometimes if you have limited ability to be able to have, let's say, Wi-Fi access, we have some families driving to local clinics, FQHCs, or even local libraries to be able to get access to their bandwidth or use their technologies for this.
Great.
Erin, this is Pip. I'd just like to also add that I had some excellent documentation from National Family Voices on questions for families to ask and how to prepare for a visit. So I will send those documents out to everybody that's been registered for this webinar.
Wonderful. Thank you, Pip. And I'm doing a time check. We did approach the noon hour. Should we wrap up at this point? Or do you want to continue with, I did just see a question pop up.
If everybody's okay, it would be great to have another 5 minutes.
Okay. So let's see here. So the question, the next question is there any specialty care that is not recommended to access via telehealth? So I think that would be for you, Dr. Marcin.
Sure. So in general, as you can imagine, the more the doctor or therapist has to use their hands, or if there needs to be testing, then that's less likely to be amenable for telehealth. But it does it is still, I would still check with your providers. Sometimes they'll just want to check with you to see how a change in the medication is or how a new device is working, and those are amenable to telehealth. So in general, it's better, it's easier to use telehealth if it's just communication and looking at your child or looking at a rash or looking at a device. But it's of course more difficult if you have to get testing done or a physical exam done. But having said that, it's really up to each circumstance. If you live 5 hours away, the doctor should work with you more to be able to do it via telehealth, for example. It's always worth asking your provider.
Great. All right.
There was another question in the question and answer section, which said from Lourdes, it says, we provide intensive case management support to parents through our nonprofit. We have supported parents in telehealth visits to get answers in their questions. Is this something you are seeing?
So forgive me, is this for case management programs?
The question came in from Lourdes Carranza, and I'm not sure.
I do, again, I think that this is a question that you should talk to your local primary care provider and your specialist providers. There are case managers that will engage over telehealth for sure. And sometimes they just need to be introduced to the capabilities of telemedicine. It may be that their clinics have telemedicine, but only the doctors are using it. But really, the therapists and nurses, the case coordinators, the social workers, the dietitians, they all should be using telehealth. And thanks to May's leadership, most often the doctors and the providers can get paid for their services this way. They just may not know it.
I can see parents reaching out to a support, not knowing that it's available or not having the knowledge or the resources to know how to ask for that service, especially in our area. But I've had to help some families utilize telehealth. So I could see some families needing that service and not laying it all back on the doctors, not knowing how to use it. I think there's families that don't know how to use it.
Yeah, that was one of the things that I mentioned in my presentation, that we need not only that provider education that Dr. Marcin talked about, providers maybe not knowing that it's covered, but also for patients and their families to let them know that this is an option that's out there, and as was mentioned, not putting it all on the provider to provide that educational component.
I also just want to quickly say too, education around how to use it, but also education on the fact that telehealth and telemedicine does not necessarily mean a lower quality of care, because I think that there is some concern around that. And I think there's some great data starting to emerge showing that the quality of care is not only comparable, but can even be better in some cases. And that it's not exclusionary, right? Like my kids still go in for labs every few weeks and things like that. But I feel like that's an important piece of the education and an opportunity we have as parents to educate others.
Very good points. Okay, well,
I'll also attach my CCS Facebook page to any handouts that you have that we've been posting for CCS families. I think Pip has that.
All right, great. All right, so I think we're going to conclude the webinar. I just want to thank the attendees for their participation, and a special thank you to our speaker panel. We appreciate you sharing your expertise, your perspective, and experiences with telehealth. And last but not least, thank you to Pip Marks and Ali Barclay and the rest of the team for all your hard work in making this webinar happen. Your passion and commitment to improving the lives of children and in families is inspiring. So thank you all and have a wonderful week.
Thank you so much.
Thank you.